India बताऊं तो એટલે તો મધી everything is live. Go live દબાઈ દીધું. બસ ખાલી go live દબાઈ એટલે ઇન્ટરનેટ કરવા પડશે. અહીંયા ભલે ઓછા લોકો આવે પણ તો આપણે બધાને બતાવવું તો છે.
બધા લેક્ચર પૂરા ભારતભરમાં
હા
બચ્ચા બચ્ચા બોલે
બચ્ચા બોલે
आजच्या रात से ते जाणून शिक नाही बच्चा बच्चा बोलेगा श्री राम
तो जे के करतो होता चार वाक्य નો કામ કર્યો તો
Ready?
So good evening and very warm welcome to all of you. And on behalf of Ahmedabad Orthopedic Society and the Gujarat Orthopedic Association, so it is my privilege to extend a heartfelt welcome to each one of you. So we are especially honored to welcome our esteemed faculties who have joined us from USA, and a very special note of thanks to our beloved Sheetal Parikh for his remarkable efforts in organizing this event. So I would like to invite Dr. Sheetal to deliver his talk. So welcome to all of you.
Thank you, Kamlesh, and welcome everyone. Thanks to Ahmedabad Orthopedic Society for organizing this EME at short notice. And we have a bunch of lectures that are lined up. I'll start with fractures around the knee. We do have some other faculty who are going to join us shortly. And we have Taral Nanda as well from Mumbai, who is going to share his views on fractures. So we'll get started with knee fractures. So fractures of the knee in children, we looked at the claims or medical negligence claims, and there were 13 cases of malpractice. 6 of them were missed, either spine fracture, one orbital artery injury was missed, secondary to medial femoral condylar fractures, and others were past and post-op complications. You can see that a lot of things can go wrong if you don't analyze the patient and the imaging appropriately. These are the list of cases that I'm going to show. So this is not a dynamic talk. Nowadays, you can get all the dynamics from your social media platforms, including Ortho bullets and a lot of online computations. We start with Pfizer fractures. So there are principles of treatment based on what type of saltinated fracture we identify on the X-rays. So here are the examples of type 1 and 2, which are extraarticular Pfizer injuries. And these are treated in a cast if they are not displaced. If they are displaced, they are close, reduced, and fixed. When it comes to type 3 and 4, these are intraarticular fractures. We would recommend CT scan for intraarticular fractures around the knee. If they are not, we would recommend doing fixation for these fractures. We look at the shape of the physis of the distal femur. It's undulating, which means that whenever there is a fracture, there is a high chance of having a growth arrest. If we look at the rate of growth disturbances after the physeal injuries around the femur, it's very high. It's almost 50% of the patients would have a growth arrest rate. So the displaced fractures have higher rates of growth arrest compared to undisplaced fractures. And Salter 1 has higher rate than Salter 4 has higher rates than Salter 1, which is intraarticular fractures have a higher rate of growth disturbances compared to extraarticular fractures. So let's look at an example. This is a Salter 1 fracture, 10-year-old female. It's a displaced fracture, you can see. I would just make this a little bit more interactive. So I'm going to ask some of our residents to see or to get their views what they would do if they have this fracture in the emergency room. So any ideas of what we're looking at? I've already given you a hint by saying the neurovascular examination is intact. Does that mean that these fractures are more prone to vascular injuries? What are the ideas? Who are the first few residents? First few residents? Okay. What are your concerns when you see this injury?
Neurovascular.
Yeah, neurovascular complications, that's correct.
Erythema, you can say.
Anything else? What would you do for this patient?
Nose reduction.
Nose reduction. And if you get a really good anatomic reduction in the ED and the patient neurovascular examination is intact, what are your next steps? Would you admit the patient for observation? Would you send them home, or would you still fix it? You can answer. If you have an anatomic reduction of this fracture, would you treat the patient in a splint or a cast, or would you fix it? Third year. Other residents in the back. Fellow.
Let's get on to junior consultants. Let's get on to junior consultants.
So I'll tell you. Even if you get an anatomic reduction, these fractures, because even if there is micromotion, they will lead to growth arrest. So these fractures are always fixed. Okay? Even if you get a closed reduction, 100%, they need to be fixed. All right. So remember for distal femur. So typically you can fix with the different ways, but typically we use cross K wires to fix this, smooth K wires, so that we don't damage the physis anymore. So you can see it's an anatomic reduction, 2 K wires, and these fractures heal really fast. 3 to 4 weeks and they would heal. So there are different configurations of how you can put the pins, but basically you pin them and then you can remove the pins in about 3 or 4 weeks. Okay? So this patient, the more important thing is to follow this patient because of high growth arrest. So this patient, you can see the physis, there is complete growth arrest. And you typically would do some CT or MRI or high imaging to look at the extent of the growth arrest. But here, you don't even need a higher imaging. This is a complete growth arrest. So you would have to deal with all the effects of a growth arrest. You may bend the patient, you may do surgery on the other side, but some form of limb equalization would be required if there is a deformity and correcting the deformity. Move on to another case, a 13-year-old boy who fell off a bike. Can anyone try to classify this fracture? We looked at the Salter-Hayes classification. Do you think that this is an extra-articular or intra-articular fracture?
It's intra-articular fracture.
Intra-articular fracture, right? So do you think it's a type 3 intra-articular or do you think it's a type 4? It doesn't actually matter. You can have a small metaphyseal fragment which will make it a type 4. It doesn't make much of a difference. But the intra-articular fragment, so the reason I said that we need a CT scan is to look at the configuration. Here we did not get a CT scan, okay? But you think that there's a coronal plane split, right? So how would you fix it? Do you think this is good enough fixation that we have crossed the fracture line?
I think, sir, we should also put a horizontal screw and along with that we should put like a transverse KY or something.
So you could put, if you think that the entire physis is disrupted, then you can put KYs just like they showed in the first case.
Yes.
So here we thought that this was an intra-articular type 3 fracture. If it's a type 3 fracture, you don't need to go above the physis, right? Because it's a type 3, it's intra-articular below the physis. So this is what the correction was. And when the patient came back in the clinic 6 weeks post-op, you can see that now you can see that the entire physis is disrupted, so it's not actually a type 3. Okay. Some of the fractures cannot be classified by Salter-Hayes classification. This had an intra-articular fracture, but the entire physis was disrupted. So the reduction was not perfect, right? It's inadequate reduction. And if you look at the CT scan, so we got our CT scan, and what you see is there's an alpha fracture, right? There's a split in the sagittal plane as well, besides the coronal plane. So we actually missed that alpha. Otherwise, the screw should be going from an A to P, right? If it's a alpha fragment. Here we were going from medial to lateral, so we missed the fracture entirely. The good thing is that the patient did not have a growth arrest. This one did go on to remodel, so we didn't have any issues. But this just brings the point that you should do a CT scan before you treat these fractures. Anytime you see an intra-articular fracture of the distal femur. So if you look at this report, it's a frequently misdiagnosis in adolescent athletes. And they looked at 49 patients, majority were type 3, Salter 3 involving the medial femoral condyle. 39% had misdiagnosis. So such a high rate of missing the diagnosis because you may not see it on the X-rays. And the displacement of CT scan was twice compared to the displacement on the X-ray. So you can't make decisions on the X-ray alone. You probably need a CT scan for all these patients with intra-articular fractures from the distal femur, and all of them require surgery. So let's look at another type of fracture, which is a patellar sleeve fracture. And this is equivalent to a patellar fracture in adults, but in kids, what happens because the physis is still there, or the apophysis, and it's a link between the skeleton and the ligament, so it pulls off a sleeve of bone and cartilage. And you can miss this. Initially I showed you the malpractice claims, but because of some missed fractures. And this is one of the fractures that gets missed as well. And what you see is that there is the patellar height is significantly increased, so that kind of gives you an idea, and you can get an X-ray of the other side to look at the patellar height, what is the normal height for the patient. And you can see that this is an X-ray of the other side. You can see, even if you don't see the fracture, because the patella is highlighted, once you examine the patient, you would know because their extensor mechanism is disrupted. You have swelling, you can feel a defect, so you know that there is something going on. But if you just look at the X-ray, like a lot of our physicians just look at the X-ray or the report, you may miss it, so it's important to see these patients. And that can be an issue of palpable defect. And the thing is that the X-ray may miss it, and sometimes the MRI can be helpful, especially if you're in doubt about what kind of fracture it is, then an MRI will definitely help. If you look at this MRI, you can see that it's a pretty big piece that is pulled off from the patella. And the diagram shows what happens. You can get a very big articular surface along with the fracture. And so you have to open this area. Sometimes you can even the patella, you can fix the articular surface with some, observable 4 or 5 monocle sutures. You can glue it sometimes, and the way to treat this fracture is different ways, but basically you can do a patella tendon repair. So you compare pectoral sutures in the tendon, put your holes in the patella, you can pull it up, and that's typically the way it's repaired. If you're a big chunk, you can do a screw, you can do tension band, but a lot of times you don't have much bone to work with, so you can treat it as if it's a patella tendon repair, and then there's this periosteum on the dorsal side. So here, it's treated with patella tendon repair with transpatellar tunnels, and then you can also subclass it, to protect the repair if you need to. And sorry, I'm just here. So this was done with the tension and wire. So that's another way of treating it. I usually would recommend using the patella tendon repair technique. Here is one of the biggest diseases that was published a couple of years ago, which is the transosteoid osseous repair of the sleeve fracture. 20 patients and 7 patients had no osseous fragments. So you can certainly miss this because there is no bone involved. And all had transosseous repair with the crack suture mixed in resulting on patients. All right. So the next one is an intraarticular fracture case. The typical mechanism for the tibial spine fracture is hyperextension and rotation of valgus. As you can see here, it's very difficult to miss this fracture unless, again, you can get small break fractures of the tibial spine where you don't have too much bone, it's just cartilage, and it's equivalent to an adult ACL tear, age 8 to 14 years. And the ACL stretches before the fracture. So if you get an MRI, there's always going to be some form of, edema, or they can say partial tear. And that's very common. It usually heals fine. You don't need to address the ACL. There may be a little bit of laxity after you fix a tibial spine fracture, but there is no gross instability in most of the cases. And you can miss it if the fragment is small and if you're not used to seeing this. And MRIs, especially if you're considering on-off treatment for this fracture, an MRI is important to make sure it's it's not significantly off. There's no meniscus entrapment. If you're already doing the treatment, we treat it arthroscopically. You can treat it open as well. But if you're going to scope it, then you're going to scope the entire knee. So it's unlikely you're going to miss any meniscal tear. It's okay not to get an MRI for patients going for arthroscopic fixation. It's classified based on this Myers and Mercury classification. Type 1, you can treat it along leg cast, and type 3, you have to fix it with screws or sutures. And type 2 can be treated either way, though my preference is to fix all displaced fractures with a screw. So when it's type 2 or 3, I usually don't attempt a post-injection. I haven't had good luck with that. So I would use suture fixation if it's a little bit comminuted or if the fragment is really small. That is when I use suture fixation. When my sand fixation is a screw. Now, what complications you can have if you miss a diagnosis? You can get marks, lead to impingement, and for the laxity of the ACL. Arthroplasty has been reported in a lot of patients, and the key is early mobilization. That's why I don't like the calf, because you put the calf, it heals, but then also leads to a lot of stiffness. So I usually like to fix it so I can mobilize them. And then instability in less than 10% of the patients. If I put a transficer screw, which is most of the time, that's what I use, then I do remove the screw in three months, so the patient doesn't require second surgery. About osteochondral fracture, most of them are because of a patellar dislocation, either from the medial patella or lateral femoral condyle. The piece appears to be smaller on the X-ray, but usually it has a big chunk of cartilage attached to it. And if it's 15 millimeters, which is what our threshold is, it's not like an absolute threshold. If you think that the piece is a good healthy piece, then you should put it back. And when we have patellar dislocation and fracture, then we fix the fracture and stabilize the patella at the same time with an MPFL reconstruction. And this is the case showing fixation of the fracture with headless screws and MPFL reconstruction, which is transficer. How about the tibial tubercle fracture? So these fractures are usually seen in athletes who come from a jumping injury, and we see a lot in basketball players who come down from a jump. And the common age is 12 to 16 years. Some reports of pre-existing osteoskeletal disease, CT scan is usually recommended if it's intra-articular and you're concerned about, whether you need to open the joint or whether you can just hinge it down or close the door. A lot of times we would not open the joint or put a scope in, we just do a open reduction of the fracture, and without looking into the joint, you can check on the floor. And if you're happy, then most of the time it's well reduced. But if there any doubts, you should just extend the incision, do a mini arthrotomy, look at the part of the fracture. So these are different types of intra-articular fractures. The one which is intra-articular and one is which has a posterior extension are the ones which need surgical fixation for sure. But besides that, we need to be concerned about vascular injuries if there are posterior extensions. They may be displaced at the time of injury and then they reduce because of recoil and you might not recognize it. And so you can get compartment syndrome, vascular injuries. You've got to be careful. These anatomic reduction usually used with and fixed with screws, like you can see here. But you need to be aware of the displaced fractures because you can see how the artery is tethered to the metaphyseal spike. So you can get some injuries, and you should do ADIs of this patient, which is the ankle brachial index, to make sure that they're not having any perfusion issues. This is the fixation of type 4 fracture with 2 screws, as seen here. Should be a case of a 15-year-old right tibial tuberosity fracture has failed 2 surgeries. Now, why would a fracture surgery fail? You look at this X-ray. So, any idea why did this fail? The patient had 2 surgeries at outside institution. Why do you think this failed? Go to back, residents. What of your residents are ones next to you? Why do you think this failed? Next to you. Why do you think this failed? Anyone, any residents or fellows?
Immobilization was not sufficient, sir.
He was immobilized for 4 weeks.
Okay.
But you're kind of right because he was allowed to go back to sports after that.
And the fixation was not very sturdy.
So you think the screw size is smaller, or number of screws are less, or what do you think?
I think screw size is smaller.
Yeah, usually these are heavier patients. If you look at their boards, these patients may not allow them to go back to jumping for at least 3 months. Unicornical screws, that's okay. But they need to be bigger screws. We frequently will use 6-5 screws, and in the diaphyseal side you can use 4-5, but on the metaphyseal side or the epiphysis I would use 6-5. So if you look at the outcomes and complications of tibial tubercle fractures, you can see that the most tenuous, or you can countersink them because there's almost a 50% rate of taking it out. Let's look at my last case here from a metaphyseal fracture of the femur. And this was the fixation. So, this is good enough fixation? Residents? What's wrong with the fixation here? Bond reduction is one. What else? Inadequate fixation. Because the 2 pins probably are behaving as one because they're so close and parallel to each other. Anything else? What do you think about the medial pin?
It's a well-done. It must be an adductor canal.
Yeah.
It's an adductor canal. Femoral artery should be there.
Yeah. So would you have done it? Would you have chosen to fix it like this?
No, never.
I just was done by an orthopedic surgeon, right? So this patient came with this, the pain of the medial side, and an avascular limb. And then we did an arteriogram, you can see the pain going right through the vascular tree there. No distal circulation. The patient ended with an amputation. So from a fracture which could be treated in a cast, this actually did not even require this. This could have been treated conservatively. It's a young patient, metaphyseal fracture. There is no need for any reduction. Okay? You can just let it remodel. You can put them in a cast and they're going to heal. So over-treatment, not only that, but complication from over-treatment and led to an amputation. So you got to be careful, especially in neurovascular anatomy. And I've got so many cases of injuries to the nerve wall sides that it would not matter, but it does matter. Yes. All right. So in summary, don't miss intra-articular fracture. Either always examine the patient. Don't just look at the X-ray. Yes. And you need to follow the patient because these are going to have some growth arrests and growth disturbances. So you need to follow them for a couple of years or till maturity. Thank you. Do we have any questions? Then let us know to stop.
Any questions for Cikal bhai? Prakash.
Which
Yes, sir.
so I'm going to talk about supracolumnar fracture because that is what Kamlesh wanted me to talk. And it's been 20 years I'm talking about supracolumnar fracture, and still there are questions. So whenever we have supracolumnar fracture session, for 20-minute session, 2 hours are not enough because everyone has questions, and it's not that every time we have answers. So let's find some more questions, and you can see in this picture that there is a technical person education about fractures in children at Pune in July. So this year too we have iFix at Pune, and now also we have iFix Express, where in a city we conduct these meeting one-day programs, and iFix Express has gone across India now to Sri Lanka and Bangladesh, and soon it's going to go to African countries also. So Kevin, once in life, I want to have iFix incident. We'll do a pediatric fracture course there. So first, coming to a technique, I'm going to take you on straight to our operation theater, where we have this 8-year-old child with a supracolumnar fracture. It's a displaced supracolumnar fracture. The radial pulse is well fed. I looked at the capillary circulation, which was good. But if you are doing this OK side, this is on the normal side, and you can see the child is able to do that. But on the fractured side, he is not able to extend the fingers, which means I have a pulse ping, but with a radiological, with a neurological involvement. And the decision is very clear that in these cases, you still have that it's not necessary to explore a nerve when you have isolated nerve involvement without a vasculature. So this is an option when you anesthetize the patient and then you are arranging in CR, is to use CR as a fracture table, as your support. It's very convenient. You need to shift the CR, you use all the support, and then the problems come. We have a very low cost solution here in form of an arm board, which you can make from any carpenter. It's a 3-inch wide board, 6 feet long, and it's made from a teakwood frame, which is around 3/4 of an inch wide. And this can be multi-purpose, from giving hip spikers to doing supracolumnar fractures with an arm board technique. Multi-purpose, and you may register for Orthopedic to get a free hip spiker table, But if you don't want to register, you can mark your elbow, and this helps the CM technician. Many times they don't know where to shoot, and this will reduce the number of exposures and will have better fertility rates among pediatric orthopedic surgeons. So this is something we should do. Marking the center of the elbow. The 50% of the surgery is about getting the right exposure and CR. So now you put the armhole to drape the patient. You keep this arm towel because pneumatic drill, if that thing is not provided. This is AP view. So first thing you do is give traction and study the AP view. Here I see it's a posteromedial fracture, which means lateral periosteum is intact, medial is little more damaged. There is a medial combination, so I know that this can go into varus if it's not fixed properly. And I know that this is a high energy supracondylar fracture, unstable variety, which I need to fix there. So this is the second step. After giving traction, sustained traction, you correct the translation in AP view. So I have pushed this fragment laterally so that I get good alignment in AP view. So you may feel happy, but that's not all. Now you have to get alignment in a lateral view. So you hyperflex, keep your thumb on the auricular and correct the posterior translation. And here I have pronated because it's the injury demands that. And now I check my AP. This is the AP Jones view. It's also known as sometimes loser's view because you neither see forearm or elbow, and there is always a confusion whether your alignment is proper or no. So you can take oblique views. So this is an external rotation view. I call it a max view because it shows you the medial column. So max is for medial column. You can see the medial alignment well. And then you take internal rotation view, 45 degrees, gentle internal rotation view because it shows the lateral column. This is what a limb view. You realize that supracondylar fracture reduction is about columnar reduction, medial column and lateral column. And if they are aligned well, you will not have secondary deformities. The lateral view is a problem. The moment you take a lateral view like this, there is a rotation on the distal fragment, so your alignment gets lost. So you want to remain in AP, yet you want to be able to lateral view. So if you cannot move your arm, it is better to move the C arm. So you move the C arm, and now you notice that there is a posterior translation. And how do you correct that? So the way to correct is in lateral view, keep the C arm in lateral view and push from posterior side, and then if possible, this is my favorite configuration. I put two divergent pins which I will pass at 45 degrees. The second lateral pin is at around 30 to 45 degrees, and it goes through four cortices. It actually goes through the lateral condyle, and it goes through four cortices. There is 30-degree deviation between the two pins. So these are two lateral pins. In a lateral view, it's important to realize the lateral pin does not go along the humerus axis. If you pass along the humerus axis, you get very little of the distal humerus. So it has to go from anterior to posterior if it's a transverse fracture. However, if you have oblique fracture, then sometimes you are forced to put these pins from posterior to anterior. So entry point for the lateral pin is almost on the articular surface of the humerus, and then you go little 2 to 3 millimeters anterior to the midline point, and then you direct on an AP view, it will be around 45 angle to the humerus, and in lateral view, it is 15 degrees going posterior. So you pass your two pins, lateral pins, and then check again AP, lateral, internal oblique, and external oblique. So having done all this, now I feel that of course I have two lateral pins, but this is still medial kind of big combination. It's an oblique fracture. This is not adequately stabilizing this fracture. So in this fracture, I decided I should also put a medial pin. Now medial pin, there is a risk of injury to ulnar nerve because inflection, the ulnar nerve goes anterior, and then it's at risk for being injured with the medial pin. So first thing you do is now it's stable, so you extend the elbow. You extend the elbow to 30-degree position. Secondly, always enter anterior because the ulnar nerve is posterior to the medial condyle. And if you are in doubt anytime, if there is swelling, if you are insecure, if you are not sure, and make a small opening, and this opening is not to explore the ulnar, it's a small opening to feel the medial epicondyle, to make sure that there is nothing between your finger and the medial epicondyle, between the K-wire and the medial epicondyle, so you are sure that it is not going to the ulnar. It also helps sometimes to use this little sleeve so that as you are passing the drill or the K-wire to the drill, it does not catch on to the sheath on the ulnar nerve and causes it to get irritated or rotated. So this is how we will do a safe ulnar pin in extension from anterior to posterior. And as Dr. Edwin Crawford has often taught us, use different size K-wires so that in lateral view, you know which K-wire is bent. So this is my fixation, 2 lateral pins and a medial pin. Again, you check for the pulse. I give a dressing, cut a gauze piece and give a dressing because while removing the slab, the wire should not come out. So small little tricks here which I am sharing with you. The slab should be given in 45 to 50 degree flexion, never in 90 degree flexion. I don't give a cast. I give a slab. If plaster is required, if it's convenient, then I will generally do it after 3 to 4 days. So you will see there is a lot of padding. These are the days when we still used to use plaster of Paris. This session is supported by ICT and we use their plaster now, fiberglass plaster, but you can see that I made some more changes in my slab. After giving the slab, I open it anteriorly so that if there is some swelling, it can be accommodated. I also made sometimes a small opening near the radial, especially cases which are big pulse present, and if I want to follow it up with a Doppler, I make an opening on the radial pulse so that it's easy to get a Doppler for a radial pulse. So when do we remove the wires? After 4 weeks, you know that callus formation is there. Remove the wires only when you are sure that fracture is deep. You don't have to immobilize this patient for 6 to 8 weeks. So 3 to 4 weeks is where you will be able to remove the wires and mobilize them. So this is complete the technique of standard supracontus. That was technique, and then 3 jugaads very quickly I will go through. One is using a hypodermic needle to guide your K-wire placement. Now this is something I discovered from a paper which was published in 2022. And where they said that using a hypodermic needle can help you. So this is again a supracondylar fracture. We also change because we have to provide new material for the delicate. So this is something which I have changed. I use now an arm bolt which is used as described by Sandeep Patwardhan, and you keep it short of the elbow because then it provides an outer traction for your posterior thing to be corrected. And then this is one more thing which I do is I use a hypodermic needle because it's very easy to control with the hand. It gives you a direction on EP and lateral where you should pass your K-wires. It reduces the K-wire perforations into the cartilaginous lateral condyle of the child, and it's easy to get this direction as compared to K-wire on the drill because it's a heavy thing. Once you get your direction on EP and lateral from this hypodermic 18 number needle, now it becomes easy for me. Now I know that my entry point is perfect, but my direction has to be little anterior to posterior. On a lateral view, on EP view, I know that this direction is okay, but I need to just increase my angle a little bit. So my K-wire now will go in that direction, and now this will give rise to a good fixation without multiple attempts and multiple Siam shoots. So this is what I found. The number of image intensifier uses will reduce. Again, you will see some differences in the technique I am doing. I am using 2 different sizes K-wires. This was after I fixed after postpone meeting at Ahmedabad. I have learned that that helps as taught by Dr. Edwin Crawford. So these are 2 different things we are doing, and just 2 wires here because we thought those were sufficient. And another jugaad I am going to show you about flexion type supracondylar injury. So this is you must recognize whenever the fragment is in flexion and not extended, this could be a flexion type injury. This child has sort of ecchymosis on the posterior aspect. That is one more clue which tells you that the damage is on the posterior aspect. This is not fall on the stretch hand but fall on the point of the elbow. And the problem is these children can have ulnar nerve injury, which should be looked for. And second issue is if you reduce this in flexion, this will display. So you must reduce this in 30-degree flexion position. So I'm giving traction, then I put my hypodermic needle, and then you can see this is on the arm mode. On the arm mode, the lateral view is very clear. Now you know that the distal fragment is going in flexion. So because the arm mode, humerus is strapped to this arm mode, now you can posteriorly translate it using a force against that resistance and get it to reduce. And now you will pass one wire in this position using hypodermic needle as a guide. Pass the second wire. This is done laterally. And then confirm your reduction. I will pass 3 wires because in this injury, for the injury side on the medial side, I didn't want to pass any medial plates. And this went on to heal very well. And ulna also recovered in this patient after around 3 months. So that's the second tip. The third tip for the day is when you get difficult supracondylar which you cannot reduce. For example, this is a 10-year-old child, but also 10 days old injury. And then this came in this status, lot of swelling, and treated by a bone center somewhere else. And there is so much of transmission. Are you going to do an open reduction? Really not necessary. What we did is, inspired by one of the papers where Sheetal has described, we did something known as intrafocal reduction. But at this stage, instead of using a K wire, as in this paper, we use an artery forceps. Because there is a lot of overlap, and K wire was not really working well. So you take the artery forceps, which is a curved instrument, you put in the fracture side, and then turn 180 degrees. So you get a hold of a proximal fragment and then translate. It looks all good on animation, but actually it will work on table, and I'm going to show you that. So this is anyway, so we reduced this with this artery forceps method and fixed with K wires as usual, and we were able to get this reduction also in a 10-day-old section. So let us see that we don't think that we get the last frames. So this is how it would reduce. I'm using the pin in the proximal fragment for derotation. So many things happening at the same time. So you're seeing 2 tricks in one case. Use of proximal wire for derotation and use of artery forceps for translation. And then you fix it. And here
You're flexing also.
flexing also. And so elbow is not in, my control is with an artery forceps. I'm not flexing. And then you can see here my wire has gone from posterior to anterior because it's an oblique fracture. If I put from anterior to posterior, I do not have a good hold. So you may have to change your strategies. And finally, you have 3 wires here. You remove the proximal pin and treat the snap. So I think it's enough for today. 1 technique and 3 tricks for all of you to go home. Thank you very much.
Any questions? Sir, whenever there is a fracture supracondylar humerus.
Kevin is next top. We'll ask him to load the top. Then you can ask.
Yeah. So, what is a supracondylar humerus fracture? Associated pulse is there, but there are nerve involvement. So, do you prefer open reduction or directly go for a closed reduction?
So multiple situations.
Yes.
If pulse is present
Yes.
and hand is pain, but only nerve is involved, then most of the time you will not do anything.
Sir.
The second situation, the pulse is present, the hand is pain. Before surgery, the nerve was good. After surgery, you have pulse. Then those you must explore. So nerve is in the fracture. Okay? If there is no pulse, but hand is pain, and no nerve is involved, you don't have to do anything. You just have to do close it. If there is no pulse, the hand is pain, but if one of the nerve is involved, especially anterior intraosseous nerve, then there are high chances that nerve and vessels both will be entrapped at fracture site. And in these cases, if the fracture reduction is mushy, or if there is anterior fracture gap, then you should be ready to expose. I think there are these 3-4 situations, and you will act according to situation.
And all the surgeries are performed under general anesthesia or block anesthesia or short GS.
So my anesthetist, we have a very good anesthetist who is master of blocks, MBA. We call him as MBA, master of block and anesthesia. So he wants to give block for everything, and we said for suprafounder, I don't want. So he said I will give a short block. There is nothing like a short block. So you must avoid blocks for the suprafounder because you will not come to know about the compartment syndrome if the child has pain post-reduction. Sheetal, what do? You all give blocks or?
No, we don't do blocks. For trauma, we try to avoid blocks. For any trauma patients,
Any trauma patient.
you need to avoid because you need to do neurovascular checks. One other situation, and there have been reports on this, is
Sheetal, talk in the mic because.
no, we don't do blocks for any of the trauma patients just because it can mask a lot of important post-op findings, including nerve assessment, compartment syndrome, pain assessment. But what we were asking about the nerve, one of the things is high median nerve involvement with the suprafounder. It doesn't happen too often. Usually, maybe with an open fracture, or sometimes it can happen if you have a pulseless head. It's important to diagnose it because if you have a high median nerve palsy, then you would lose sensation in the. So you can have a compartment syndrome without the patient, crying or feeling any pain. So you're going to miss a compartment syndrome. So it's called a silent compartment syndrome, and then it reports on that. So you need to make sure that you do a really good neurovascular assessment. And that's one of the keys of suprafounder fracture is to document your neurovascular assessment before you take the patient to the OR. Okay. Even if the patient is crying, even if the patient is non-cooperating, you try and document whatever you can and try and get a good exam if you can, because it's really important.
You have done a full reduction. You have done a full fixation on table, you are happy. But how many times you have felt in follow-up that reduction is lost with the 2 or 3 products? And then what you do?
So
Because you take X-ray 4 weeks ago.
So we take X-ray at 1 week, but if your on-table reduction is good, if you have stressed the fraction in internal and external rotation, and if that has not been moved, generally we will not lose reduction. So I've not seen it happen. Sometimes we get delayed cubital pulse. Your fixation is good, it's healed well, but after 6 months or 9 months or a year, you start seeing some pulse. And that is generally because of something known as avascular necrosis of truncated, where there is a facial affection. Because it's especially in a low component. But if you're fixed well, loss of reduction is also.
The other thing is that you do not need an anatomic reduction for suprafounder. Translation can be modeled, a little bit of annulation can be modeled. You need to make sure that the Bowman's angle on an AP view and the anterior humeral line on the lateral view. As long as those two are intact, you can accept a little bit of rotation with small spike on a lateral view, or even some translation, and things would be modeled. So it doesn't have to be anatomic, otherwise you end up opening a lot of these fractures because you think that you need a perfect reduction, which you don't.
Well, there is a significant displacement of the suprafrontal fracture, and there is a being pulseless and median of injury. Do you do the open reduction or do you try the close reduction? And after the close reduction, if you feel there is a median of injury and pulse is not there, saturation is 99, and the movement is good, but there is a intra-interstitial involvement. What do you think? After reduction,
Yeah. No, I would still treat if it's a pulseless but a perfused head.
Yeah.
I would still treat it without opening it. If it's an anterior interosseous nerve injury along with it, that doesn't change anything. The only thing is if I don't get a reduction good enough and there is a gap in the reduction, then I would suspect something interposed, but if the reduction is there, like an anatomic reduction, then usually there is nothing that I'm going to be doing differently. Now the threshold changes a little bit if you have a pulseless hand, but you are not really sure about perfusion, like you cannot Doppler the vessels. So that's the next thing we do when we do the pulseless, if you have a pulseless hand or a perfused hand, we would reduce the fracture. But after reduction, putting your K-wires, you get the arm in a little bit of extension. Most of the times you should be able to at least Doppler the pulses, okay, even if it's a pulseless hand. And if I don't have any Dopplers, then
In 2 months, I have 2 cases where one, initially the fixation was done for being considered median nerve palsy, and the Doppler suggested that the artery in between the fracture sites. Then exploration was done and removed the artery and refixation completely okay. Second, the same thing happened. There is a pink pulse and median nerve palsy. And before, after, and then after fixation, and the Doppler suggested there is no artery inside the fracture. There is the median nerve injury, and they don't conclude anything about the nerve and what is the status. And I asked the 2 vascular surgeons what we do, we should explore or not. And one says no, it will recover, no problem. And the second says no, we have to explore. And there is the median nerve palsy. There may be a median nerve in nerve. And
Yes, I mean,
they decided to explore. There is artery in between the fracture site and the median nerve lying posteriorly.
yeah, I mean,
Remove
with
the-
that, so median nerve injuries are not that common. Like high median nerve injuries are not that common. So whenever you have a brachial artery, like means a pulseless hand and a median nerve injury, then the suspicion for a vascular injury is even more. So, then I usually call him because he's the one who does our vascular assessment. So I have that's another thing is to have someone close, your friend, or you need to call someone, in the middle of the night, you need to have someone that you can depend on. So I would just, with that, I think we'll move on. We have a lot of speakers. I'll introduce Kevin, who has joined us, several times, and I'm really grateful to him for, helping us with the mission trip here in Ahmedabad, as well as I'm really lucky to have him as a partner because he's a backup on call for all vascular injuries, and it's a good help. So on to you, Kevin.
The risk of not exploring and missing is huge. So it's very easy to explore. You make an incision, you spread twice, and it's all open. So it's easy to find. I'm going to talk about complex distal radius fractures because it's very common, right? Kids fall all the time. And we're seeing more and more complex injury patterns because of lots of different reasons. Risk in kids are complicated, right? There's a very complicated anatomy, but there's a good soft tissue envelope that helps the healing. So they almost all heal except that case we just finished. Why that didn't heal, we don't know. But in most cases, the ligaments are stronger than bone and cartilage, so you should watch out for occult injuries that pull off pieces of fascias. Most of these injuries happen at the home or around the home up to age 6, and then in playgrounds, and then older sports for us, football, or maybe cricket. I see a lot of cricket injuries in my practice with finger injuries. When I find patients, I want to get a little bit of the history, how they hurt themselves, what was the mechanism of injury. Any treatment, you see a fracture that looks good on x-ray, but maybe it was really crooked and it pulled on it and it's straight. So you're like, I've seen that happen a few times. And then the neurovascular status makes you. And if you can't find the precise location of pain, we're looking at the arm inspection, palpation, finding points of tenderness, and range of motion, especially the fingers. If you're looking at distal radius fractures, how do the fingers work? Was there a sign of nerve injury or entrapment or something? And then get good radiographs. X-rays are really important to get a good AP. Sometimes a skateboard view. Advanced imaging for concerning fracture patterns, CT or An MRI can be helpful, especially if you don't see anything on an X-ray. An MRI might show ligaments or cartilage injury that you don't want to see. For me, if I see a fracture on X-ray, I want to see if it's in the joint or what pieces are involved in a CT scan. So things that I don't worry about, these are some problematic cases just to talk about. For the short time I have. So this kid fell off a jungle gym. Bilateral wrist pain. Left was really bad. Right, not so much. And so reduced suspended in ED. This was the right wrist. It was called a buckle fracture by the radiologist. But if you take a closer look at the X-ray, it's really a saltaris 2 fracture, or I say a buckle Harris 2 when I show it in the clinic. And so with that, you have to worry more about growth arrest. So most people were worried about this fracture. Saltaris 2 also reduced, but this one not reduced. See the fracture line going to the growth. So the left wrist was followed weekly until healing. The right wrist healed well. But then she developed persistent onset of wrist pain. And you can see developing a growth arrest very subtly. So we get an MRI, it showed a 35% fascial bar from a buckle fracture. And then TFCC therapy that onset of wrist pain stimulation. Arthroscopic repair of TFCC. And then epiphysiodesis of the sternum. So it's a complicated injury. It doesn't look so bad. Sometimes it's sneaky, right? The really bad fracture, that's the one everyone worries about defining the problems. So this is a 14-year-old had a bad injury, tackling football, open wounds, get numbness, median nerve distribution. These are the best exercises you can get. So he's skeletally mature. We did a big IOD open fracture. Or I have this raised fracture, carpal tunnel release for the median nerve. We didn't want to do an opening of the ulna to cause more soft tissue trauma, so we made it. And then I went out of town the next day, and unfortunately developed compartment syndrome. And I'm taking the OR on my partners. Being one of my partners that can help me out of town too. So watching months of post-op, he came back to see me for another injury. He's doing great, no problems, full range of motion. Still playing football. But the high energy injury, those ones that you worry about, you have to watch for the soft tissue stuff too. Third one, the interarticular fractures. This kid has a type 1 OI, very few fractures, and a mild deformity from the wrist. No numbness, tingling. It looks reasonably good. It was reduced in the ER and then casted for 4 weeks. But because it's a articular shearing fracture, it's not diagnosed as a bad injury until healing. And then you can see, get a CT scan, it's healed. Take the step off, no extension of the wrist, and then a lot of them as well. So at this point, she's healed, but healed in malunion because these boulder shearing fractures. If you see the fracture plane like this, the carpus follows the boulder fragment, and so the whole wrist joint will fall apart. And with OI, you need to do something. I hate to put a place in OI, but when you have a bad intra-articular osteotomy, then you have to do that. Of course, I did a boulder osteotomy, and then I fractured the dorsal cortex because she has an OI. But I put a plate of screws in, and I get her to heal. She's hard removal early. A little bit of malunion, but not bad. And doing great 1 year out. Last kid with a problematic wrist fracture. Injury in football, we see this all the time. Fall, break their hurt their wrists, keep playing the rest of the year. And then the next year rolls around when they're trying out for the sport, they have wrist pain, so they never see me. But mostly it didn't hurt too bad. And of course, mom is a radiology tech, so mom takes x-rays and never got an x-ray from her because we're medical providers. Do that for my case too. First off. We got an MRI because you can see the scaphoid fracture on CT scan X-ray, and then it shows an avascular non-union of the proximal bone. But unfortunately, in our experience, in kids younger than 21, probably you don't have to vascularize the distal ring until the proximal scaphoid. It heals pretty well on its own. just with stabilization. The stabilization does not need vascular. Putting a screw across it can help bring blood supply into that small piece of bone, and then the single integrated screw or dorsal approach just raise bone graft into the defects. So there's two cases I think of things that I think about when I see 100 fractures in the hip disarrays. There might be one or two that you need to know that are going to be bad and worry about. These are the ones that show. So from that, I welcome any questions, and I hope you invite me back again.
Yes, question?
Yeah, great talk, Dr. Willow. My biggest question is like, what looks subtle on a Salter Harris tube buckle fracture? Do you counsel every single patient like that they're going to possibly have a growth arrest? My question is, do you counsel every single patient like after it happens?
So I tell every patient with a Salter tooth fracture that 1 to 3% chance of growth arrest, and I monitor everybody X-ray in 3 months and 6 months. And so we've got a bunch. I think it's better to take an X-ray and catch it early to do a distal microcedesis than wait until 2 years later. I just took care of a kid that one of my partners saw just raised Salter tooth that was pinned. And after 6 weeks, said he'll fall off, you'll be fine. It starts to hurt wrist, but you want to catch it early if you can. So,
What do you see in 3 months that I should be looking out for? So maybe 6 months, I probably am going to see it. But what do you look for in 3 months?
so 3 months you can tell in a lot of distal radius fractures that are growing. You can see the growth from the 1 month to 4 month healing. So you can see growth and you know they're growing. If the ulnar variance stays the same and they're growing, then you can say they're doing great. A lot of times I'll see them in 3 months and say, I'm not sure, come back, it's 3 more months. We'll take a look at it. And then usually by 6 months we know for sure. But I'm not sure if that's.
But if it's an undisplaced Salter fracture, 1 or 2, I usually don't see them back, but I explain them that you need to keep a watch on it. If you see deformity, if you see anything in future, then come back, because as you said, what am I going to do if the number of fractures that we see, means undisplaced Salter 1, sometimes even occult fractures that we don't know they're true Salter 1 and it's really MRI. So those fractures are Salter 2 with very faint line. I don't see them back. I put them in a cast, and they come back to get a cast off with the technician. But I explain them. Now so probably 1% or less than that may get affected, but the Salter Harris or the Pfizer arrest has been reported even with a metaphyseal fracture. Okay, like Salter 5. So there is no way that you can even if you screen all these patients, there's no way that you're going to be able to prevent anything. And as far as treatment is concerned, I can treat them if they have a problem. Right? So I tell them that there is a small risk. Just keep an eye on it. If there is any issue, come back and we'll get X-rays done. So it's a little bit different approach, but as long as you tell the family, then probably you're responsible. You're at least letting them know up front that there's a small chance. But I don't see them back.
I really want to go look at all of our thousands of Salter Harris tooth fractures to know which ones go on a growth arrest. Because I think there's a large amount of those non-displaced or not too bad ones that will not have growth arrests. But I think in my experience, the ones that are more displaced, like displacement is the biggest risk factor, and then age, post-UR maturity. So kids under 10, I say I don't even think it's going to be something to worry about. But if you're 12 and older with a big, dorsal, like high risk to me, like 50-80%, I think. So overall numbers are low, but there's some high risk ones and big ones.
With that, I will introduce Andrea Chen. She is also not a first time in here. She has come here multiple times. I really thank her for all her efforts and helping us out with the mission trip. She's extremely well trained pediatric hand surgeon, and she works in Toronto. And welcome.
Thanks so much. I appreciate you having me here. Thanks for your invitation. Sorry, I want to apologize for my apologies. I did a lot of post-traumatic cases here to highlight these lesions. So this is an 11-year-old guy. He's healthy. He had a fall playing basketball, and he sustained a right elbow injury. He had swelling and pain in the seat in the emergency room. And he was told no fracture, go home. And so, take a look. Perfect. Our radiocapitellar line looks aligned. We see our routine growth plates at this stage, what we expect. We go back to our textbook and make sure every little thing that we see is present, not fractured. Perfect. It's pretty good on our matches with our APP here. And so this is all we need. Do we need a test? This is Kawhi Leonard from Toronto Raptors. This is a slam dunk. This is actually a famous photo taken by my friend in high school. So this is a slam dunk. Just put a cast on, feed it back in a week, and then take it off and get them going and moving. Well, that brings us to the concept of the trash lesion. So what is that? What does that mean? And so it's an acronym that was formed by the Boston group called the radiographic appearance seemed harmless. In general, it refers to the pediatric elbow as a very benign and innocuous appearance on X-ray. And these often involve osteochondral intra-articular lesions that really are not visible on plain films because of the immature skeletal age. And if they are missed, they can result in chronic, long-term dire consequences. So the typical scenario would, children are about 10 years old, they have a higher energy fall, and clinically, their pain and swelling really do not match the radiographic appearance. So these kids with high energy, very swollen, take a further look at the X-ray. And so from that paper, the point of trash lesion, they have multiple injury patterns that fall under this category, but I really want to focus on the radial head because I've seen a lot of these and a lot of these are missed. And so I'm going to bring you to a case example that I saw in Sickkids. So the 6-year-old girl, she tripped over a ball, and that was in June. And she's at an outside hospital, said nothing wrong, treated and cast. And at the 1-week fracture follow-up at that hospital, the surgeon takes a look and says, go to Sickkids. And so she comes to our Sickkids fracture clinic 3 weeks, about 3 weeks following her injury. So take a look at her initial radiographs again. Everything looks okay, alignment's good, I don't see anything too terrible on here. But then her 3-week radiograph at Sickkids starts to show this here. And so we got an MRI, and again we can see now there's a large intra-articular radial head fracture. It's displaced. There's a gap. There's some subluxation. There's junk in the joint. And so we took her to the operating room, and you can see she had a very large, almost half the radial head with some combination here. And so we had to fix that, but that's, at least on X-ray, very, very benign appearance, but again, a highly swollen elbow. And she's just lucky that something appeared on her X-rays at 3 weeks. Okay, so that just fixes this couple of 1.3 screws. So that brings us to the intra-articular radial head fracture. And so this is a study that was done of just looking at intra-articular and extra-articular radial head fractures. And this is pretty rare, only 4% in that retrospective study for intra-articular radial head fractures. The average age was about 8 years old. And so at initial evaluation, look at how low the numbers are. So these are missed fractures, or not correctly identified. So 15% not correctly identified as a radial head fracture, and rather as a neck fracture. And up to 25% of these intra-articular fractures were missed at initial visit. So if we come back to our first case, the case that introduced our young boy with the elbow injury, he now comes back, but 3 years later. He's 14 years old, he's got elbow pain, he's got swelling, stiffness, he's got decreased flexion extension arc, decreased supination, pronation. He has no instability, frankly. And these are his x-rays. So now, sorry, I don't have a great lateral view, but now what we see is this very misshapen radial head, malunion, non-union, with a gap, and some arthritis on the form. So what if we take a look at the original films and take a look really, really closely? We blow this up